Hi, everyone. Welcome to the SAEM Advanced Research Methodology Evaluation and Design course online lecture titled Opportunities in Geriatric EM Research. As we begin today, please write down and save any questions you may have for the end of the presentation. There's a chat box in the lower left-hand corner of your screen where you can enter your questions during the Q&A portion of the lecture. This presentation is being recorded and will be emailed to you shortly following today's session. And now, it is my pleasure to introduce to you Dr. Anthony Rosen. Dr. Rosen is a researcher in elder abuse and geriatric injury prevention at Weill Cornell Medical College and a practicing emergency medicine physician at New York Presbyterian Hospital. He completed his residency training in emergency medicine in 2014 at New York Presbyterian Hospital and completed a geriatric emergency medicine fellowship at Weill Cornell in 2016. He received his MD from Weill Cornell Medical College and an MPH in epidemiology from UCLA. Dr. Rosen's research focuses on improving identification, intervention, and prevention of elder abuse in the ED and other healthcare settings. Recently, he received an R01 from NIAAA to explore healthcare utilization among elder abuse victims using Medicare claims data and data mining / machine learning approaches with a goal of identifying patterns that differ from other older adults to aid in early identification. Dr. Rosen has assisted in the development and evaluation of clinical protocols in ED assessment / management of agitated delirium and appropriate use of indwelling urinary catheters. It is a pleasure to have him present today. Dr. Rosen, I will now turn it over to you.
Thanks, Mr. Landry, and thanks everybody. Hopefully you can hear me. As Mr. Landry said, I'm an ER doc at Cornell, which is in New York City, and also very interested academically in geriatric emergency medicine. And I'm hopeful that this presentation will be helpful to you folks. It's exciting to be invited to participate in and to present for the armed course. You guys are all of our future as emergency medicine research, and hopefully as geriatric emergency medicine research. And this is the first time that I or that someone focusing on geriatric emergency research has given a talk as part of this course. So hopefully it's helpful, but I'd also be looking forward to feedback if there are parts that are not particularly helpful. So let me start. I have no financial conflicts of interest to disclose. I'm lucky enough, as Mr. Landry mentioned, that colleagues and I have research funded and clinical programs funded from several organizations. So here's what I'm going to talk about: opportunities in geriatric emergency medicine. Now, probably noticed from our clinical practice are a growing population of ED patients. There's increasingly a focus on and optimizing clinical research questions. Most importantly,
Hey, Dr. Rosen, I'm going to ask you to back up from the phone a little bit. You're garbling.
Sure.
Thank you.
Sorry, guys. There are specific funding mechanisms for this type of research. I think there are real opportunities to integrate older adults into research in emergency medicine in other areas. And then there's an extraordinary mentorship and a very supportive community within geriatric emergency medicine that I want to make sure that you're aware of. So first, our future. It turns out that U.S. older adults aged greater than 65 will double to 83 million by 2050, and the oldest old will triple during the same period. In fact, it's sometimes called the silver tsunami, but realistically, what it means for us, because of aging baby boomers and increased longevity, we're going to be seeing more patients. In addition, older adults are actually increasing how frequently they choose us, how frequently they seek care in emergency departments. And so as a result, predictions suggest, or projections suggest, that older adults may represent as much of a third of ED patients by 2030. 1 out of every 3 patients we care for. And it turns out, and this is really, really important, older adults, and this is what we teach residents, of course, right, guys and gals? Older adults are different than younger adults in the emergency department. They often have multiple chronic issues, atypical presentations of disease, and cognitive impairment. They're more likely to arrive by ambulance. They require more laboratory and imaging tests and greater social services. They have longer ED stay lengths. They're more likely to be admitted. They more likely require the ICU, and they have a higher rate of adverse outcomes after discharge. I have a colleague and friend who gives a version of this presentation, and he often asks residents, what percentage of your patients do you think are older adults? And they always answer like way more than it actually is, because these patients take a lot of our time. And so as a result, even if the national averages are about 20% now, it's likely that it feels more like 25 or 30 or even a higher percentage, because these are patients that we spend more time on. These are patients that we think more about. These are patients that take more time to appropriately and safely disposition. Recognizing that older adults are different and that older adults might require a slightly, or perhaps a more than slightly, different approach to emergency care is an idea that's not new. In fact, this is the first publication in 1982 recognizing this. There's another publication from 1992 and one from 2003. Here are the pioneers, or the giants, the Mount Rushmore, if you like, of geriatric emergency medicine's early phase. Lowell Gerson, who has a PhD in Ohio, and Art Sanders, who's an emergency physician at the University of Arizona. And they were at the very vanguard of recognizing these differences and the importance of focusing different approaches for emergency care for older adults. However, in general, the importance of geriatric emergency medicine was pretty underappreciated within our specialty and outside our specialty up until 10 to 15 years ago. In fact, if you think about it, ERs are designed for acutely ill and injured patients. That's who we train for, right? We train for heart attacks and strokes, and I got hit by a bus, and I'm having some chest pain at lunch. There was very little consideration for the unique needs of the elderly. Limited formal expertise, little equipment, and few policies focused on the care of these patients. One dramatic example, and many of you may have been working clinically at this point, but many of you perhaps were not. There was an important IOM report released in 2006 called Hospital-Based Emergency Care at the Breaking Point. It highlighted that our emergency departments, and this is 14 years ago, were already overburdened, underfunded, and highly fragmented. It was a 3-volume report. One entire volume was devoted to pediatric emergency care, and 3 pages total were devoted to geriatric emergency care. So realistically, up until recently, this was not a major last 10 to 15 years, increasing recognition that quality ED care has the potential to make a dramatic impact on an older adult's health, both in managing their acute complaint and in potentially identifying and intervening to address functional decline. A friend and mentor of mine, Eula Wong, who many of you may know, she's now at Yale, published this paper in 2010 describing the geriatric emergency department. Perhaps we should be focusing on not only care protocols, but also physical changes and methodology changes to focus on an emergency department that is geriatric friendly. In 2014, geriatric emergency guidelines were published. These were a co-effort of the American College of Emergency Physicians, American Geriatric Society, the Emergency Nurses Association, and of course, the Society for Academic Emergency Medicine. And they focused on staffing, education, enhanced policies and procedures, transitions of care, equipment, and performance improvement measures, all of which might improve care for older adults. The C-shift, and many of the leaders in our field work on these guidelines. Since then, this has been funded by the John A. Hartford Foundation and the West Health Institute. The Geriatric Emergency Department Collaborative was developed. This is a nationwide collaborative committed to improving the care of older adults in the ED to reduce harm and to improve healthcare outcomes. It really focuses on geriatricizing community ERs through collaboration with local leadership, on-site boot camp workshops, assistance with quality improvement projects, and information sharing. It works to define, disseminate, and measure the impact of best practices in geriatric emergency care. They have regular webinars, and the emergency departments that are members of this collaborative, and many are joining now, use rapid PDSA cycles to transform care. And if you're curious about this collaborative and all the resources that they offer, you can look out on their website, gedcollaborative.com. This collaborative is led by many folks throughout the country, but the chief folks that are focused on it include Chris Carpenter at the Washington University, Kevin Bice at the University of North Carolina, Tess Hogan at the University of Chicago, Eula Wong at Yale, Don Milady at the University of in Toronto. Although there are many, many other folks involved in it as well. In addition, the GED Collaborative has developed the Geriatric Emergency Care Applied Research Network. This is led by Eula Wong and by Manish Shah, who's at the University of Wisconsin-Madison, but particularly by Eula. And they're establishing research priorities and standardized data approaches and measures for common geriatric emergency care syndromes. They're building a validated data bank to support opportunities to conduct geriatric emergency care research, and they're facilitating future multi-center pragmatic trials, dissemination and implementation studies, and other interdisciplinary projects that will further the advancement of best practices. I believe they are going to be releasing pilot grant opportunities. This is also funded by the Hartford Foundation and West Health Institute, but receives most of its funding from NIH, from the National Institute on Aging, and I'm pleased to report that the 2.0 version was just recently funded. So this is a really exciting initiative that many of us have been a part of to improve geriatric emergency research. Also, as you may have heard already, geriatric ED accreditation is now occurring. So just as your trauma center can get accredited by the American College of Surgeons for level 1, 2, or 3 trauma status, in fact, ACEP has launched, I serve on the board of governors, as do many colleagues and friends, for geriatric emergency department accreditation at levels 1, 2, and 3. This slide is actually a bit dated. There are almost now 200 accredited Geri EDs. In fact, many of you on the line may already work at accredited geriatric emergency departments. And this accreditation process allows the field to identify best practices and to measure and benchmark whether individual emergency departments are reaching these best practices. And so that's a really exciting next step that recognizes the importance of the care that we provide to older adults. And this is why I'm here, despite the fact that there's a lot going on, there are a huge number of unanswered research questions. Geriatric syndromes, do we screen and how do we manage delirium in the emergency department? Assessment and prevention of falls, which by the way, is about the most common reason for anyone of any age to present to an emergency department is an older adult falling. Medication management and polypharmacy, optimization of transitions of care, screening and assessment for elder abuse, which may be a smaller topic, but it's an area that I'm particularly interested in. And then also the impact of geriatric ED and interventions on older adult patients on the outcomes. Evidence is needed to support recommendations for a 2.0 version of the guidelines. In fact, the guidelines are supported by evidence. We need much much more evidence. Many of the recommendations in the initial guidelines were based on expert recommendation. And so there is a desperate need for increased evidence to support what we should be doing to optimize care for older adults. Obviously, also, we'll direct some of the talk later in the presentation to folks that are thinking, gosh, I'm glad I logged into this maybe, but this is not my area of academic interest. In fact, virtually any ED syndrome that you might be interested in studying, whether it be head trauma or sepsis or kidney injury, differences between older adults in young and younger patients in response to ED assessment and treatment for common conditions are critical. I think we all know that most research is conducted on younger people, and most findings that we have are likely related to interventions on younger people. And we also know, I think, that older people react pretty differently to a lot of the assessment and interventions that we have in our emergency departments. But again, one of the things that's really, really, really important to think about early in a research career is funding. Obviously, funding is a critical component to demonstrate the next steps to get you the protected time that you need to conduct the research that you want to do, and also to fund the exciting activities that you're hopefully engaged in this course to be thinking more and more about. And so a key part of this presentation is telling you about specific funding opportunities that are available in geriatric emergency medicine. Things that you may know about, but you may not know about. Things that other folks in emergency medicine have really taken advantage of. And so I want to tell you about each of them. There's the GemStar, the Beeson, other NIAAA support, and foundation opportunities. This, of course, is in addition to all the available funding opportunities that you know of already for emergency physicians. This is just additional opportunities. What we've often heard and said in geriatric emergency medicine is it's a small part of the specialty, but quite a well-funded part of the specialty. So first, let me talk about GemStar. I don't know if all of you know about it or just few of you know about it, but GemStar stands for Grants for Early Medical Surgical Subspecialist Transition to Aging Research. It is intended to provide support for early stage clinician scientists. Perhaps it sounds a little like you guys, or at least some of you guys and gals, who have recently completed their clinical training in any medical or surgical subspecialty. And the purpose of the research is to establish a track record in aging research in their specialty area. This is classically thought of as a bridge to a K award. It is something that people often apply for before a K award. You can have this, and after getting this, you can then get a K award. And so in that regard, it's a really good opportunity for folks that are at the beginning of their research career and are interested in applying for NIH funding. This is NIH, or of course NIAAA, which is part of NIH, National Institute on Aging. So what's the grant? Well, it's R03 funding, and I'm going to talk in a second about why that's really important. It's R03 funding, $100,000 a year for 2 years in direct cost. There is no requirement for it to be a specific amount of your salary. Many people use substantially their salary as far as there is a protection requirement like there would be for a K award, for example. It's for 2 years, and typically you have to apply for and identify additional career development funding of the year, but this has been done in the past and by EMF, which is of course part of ACEP, and also by AGS. And so it's quite a generous award. And not just a generous award, this is an award that you can also get a K award afterwards. In addition, there's attendance at meetings with comprehensive mentorship sessions by national leaders at NIH. In fact, this meeting just occurred a few weeks ago. Of course, it was virtual. But I want to pause for a second before I talk more and highlight for just a second that this is an R03 mechanism. This is an, and again, I don't want to get too far into the weeds, but I want to make sure that as junior research folks, or I shouldn't say junior, as growing research folks, you understand some of the issues that your chairs are going to be focused on. And R03 means that this award has full indirect costs associated with it. So in other words, if your indirect cost rate is 50% or 60%, your K award, when you get it, is not going to have that full amount. K awards are capped. However, R awards are not. And so your for the 2 years that you have this chair is likely to regard it as a much more positive award and then a K award because of the increased indirect. That doesn't help your research, frankly, but it may help your conversations with your chair around protected time because of the indirect costs that may be going at the very least to the institution, but perhaps, depending on the institution, some of those indirect costs may be recovered by your department. So let's talk a little bit about the GEMSTAR. How often has this particular funding stream been taken advantage of by emergency physicians? Well, it used to be called a Janigan Award before it was a GEMSTAR Award, and believe it or not, 24 emergency physicians, emergency medicine recipients from 2002 to 2019. 24 folks. A wide variety of research topics explored. As you can see, I've given a list here, a very limited list, but you can see the broad spectrum of things that people have used to apply for as their science and gotten funded as GEMSTARs. We actually, in the bottom right, you can see colleagues and I worked together on a paper to describe the impact of this specific funding mechanism on recipients and on the development of our subspecialty. And now, not everybody has stayed in geriatric emergency medicine, but of these 24, 2 are now academic chairs and 3 are vice chairs of research. The former GEMSTARs have been PI or COI on 126 grants, and they've all published a median of 33 articles, including folks that have just gotten the grant based on the research that we did. This is now a few years old. And this is some of the narrative that we got in this paper when we sort of surveyed all of the previous GEMSTAR folks. This is a critical grant that should continue to receive support from the EM community. It provides both critical early investigator funding, but amazing opportunities for mentorship, collaboration, and professional development unmatched by other grant mechanisms. The SAEMF and EMF contributions to the Janigan have been critical for the development of geriatric EM as a specialty and the research we do within it. For those that were funded are already increasingly the leaders in geriatric emergency medicine research, and emergency medicine research more broadly now. So that's, I think, a really exciting mechanism, and one of the things that you can and should be thinking about when you think about where you might apply with your own research ideas. Then the next thing is the Beeson. Beeson is short for the Paul Beeson Career Development Award in Aging Research. It's a K76, so a slightly different mechanism than the K01 or K08 or K23 that you're typically thinking of. It does have the same limitations on indirects that other K awards do. And this particular grant is intended to develop a cadre of clinically trained, early stage investigators who have begun to establish research careers and have shown signs of leadership potential, who can have a significant impact on the health of older individuals in their field of expertise. And this is classically thought of, and I apologize for the photograph, but this is classically thought of as a K award on steroids. It is $225,000 per year without a cap on the salary that you may receive as part of that. Of course, the NIH salary cap still applies. For 3 to 5 years, there is attendance at the annual Beeson meeting, which is an extraordinary meeting with extraordinary mentorship from alumni and national leaders. It's really kind of a club, which has been really, really beneficial. And this award has had 7 emergency medicine recipients, and 5 of those recipients have already obtained R01. And before I go any further, I want to pause and highlight that NIA, the National Institute on Aging, thinks of this as a pathway. 6 of the EM recipients of the Beeson held the GemStar before. And that's true not only in emergency medicine, but in many, many, many subspecialties. And this is the pathway that they intend. They want you to apply for and receive a GemStar, and then in a few years, apply for and receive a Beeson. And these are folks that have done this in very different topics, in EMS-related evaluation, in UTIs and management of UTIs, in falls, in goals of care, in vitamin D supplementation. NIA also is devoted to geriatric emergency medicine and to emergency medicine in general. I think, and again, I'm biased, but I think more than many other institutes. In fact, recently, there was a recent RFA that many of you may be aware of, a collaborative network to optimize emergency care for older adults with Alzheimer's disease and related dementias. This RFA was actually, we became part of the GEAR network, and that was the winning group for that particular RFA. But actually, NIA issued an RFA specifically for emergency medicine. Also, NIA is one of the 12 institutes participating in a recently released Notice of Special Interest that you may have noticed, research in the emergency setting. And so wherever you're applying, wherever you are currently, you need to read this Notice of Special Interest and make sure that you're aware whether the institute or institutes that you're interested in applying to have this or are part of this Notice of Special Interest. Also, and I would be remiss if I did not point this out very, very emphatically, Alzheimer's funding has dramatically increased NIA's size. In fact, if you were to look at all the NIH institutes and rank them by the amount of funding, NIA jumps like several spots because of the increased focus and the increased appropriation by Congress of research funding to Alzheimer's disease. And so if your work is at all related to Alzheimer's disease, or maybe related to Alzheimer's disease and emergency department care of Alzheimer's disease, I would encourage you to think about that strongly in your application. And the reason for that is that the pay lines, and again, if you aren't yet familiar with pay lines that's an important part of being an academic researcher. That's, in other words, that's the score that you get on your application that it will get funded at, are very different for Alzheimer related applications than they are for other applications at NIA, for example. And so if you're thinking about Alzheimer's disease as a potential area or topic of interest for you, I would say definitely think very, very seriously about it. And also, I will share with you that when colleagues and I go to NIA meetings, they say, no matter what your research is, if you've thought about Alzheimer's disease, probably the time to think about it. And so this is advice that junior people like me, but also much more senior people are getting and taking advantage of as well. This is Sue Zeman. Sue Zeman is an amazing program officer at NIA. She's in the Division of Geriatrics and Clinical Gerontology. She is the PO for the GemStar program. And so if you have questions about the GemStar program, you're likely going to reach out to her anyway, or may think about reaching out to her anyway. She is and has been very supportive of emergency medicine early stage investigators, to the point where she's actually attended the SAEM annual meeting multiple times. She spoke at our AGEM, which is the Academy of Geriatric Emergency Medicine business meeting, during the last virtual session. And so she is truly devoted to supporting early career geriatric emergency medicine researchers. And so if you have a specific games page that's related to this topic and you'd like to get her feedback, I would think that she might be somebody that would be receptive. She's also a really nice person. I wanted to share with you foundations. These are foundations that traditionally have focused on geriatrics and geriatric emergency medicine. So when you think about to whom you're applying, in addition to the list of foundations that you might already have, if geriatrics is your topic, then I would think about at least looking at funding opportunities in these foundations. And then also, colleagues and I have received foundation funding from local and regional foundations, which are focused on older adults. Older adults are a topic that many foundations are particularly focused on. Okay. Now, as I said earlier, many of you may have thought, gosh, I know I was supposed to log into this webinar because I'm part of the ARM course, but I'm not really interested in geriatric emergency medicine. That's not my topic at all. I'm a trauma guy or gal, or I'm a sepsis person, or I'm a biome of the microbiome of stool, or I'm focused on machine learning and how machine learning relates to bounce backs in the emergency department, or I'm somebody that focuses on specifically on women's health, and so on and so forth. I want to focus you guys and gals things. First, the 2019 NIH Inclusion Across the Lifespan policy. As you may or may not be aware, NIH now has a policy that individuals of all ages, including older adults, must be included in all human subjects research conducted or supported by NIH, unless there are specific reasons not to include them. So obviously, I suppose research on pregnancy would probably not include older adults. But in general, virtually all human subject research, there are going to be a need to at least consider including older adults. In addition, though, I would encourage you in general to include older adult subjects in your work, whether it's on head trauma or sepsis or whatever specific topic, and then to conduct subgroup analysis and submit GERI-specific grants that look at your area, whatever it is, with an interest of interest, with a focus on older adults. After all, as I've said, and as I think you know from your clinical practice, no matter what the topic is, older adults are different and they're likely to react differently. And so this is a way for you to think about additional research opportunities, whether they be follow-up grants, whether they be no-cost extension related issues, whether they be additional funding that you can add on to your existing grant, and so on and so forth, whether they be repurposing a grant and sending it to a new place because you have a new focus. So I think that strategically, from my perspective, I think that may be helpful from a grant perspective, but way more important, I think we need to learn more about our older adult patients, which is going to be more and more whom we care for. So AGEM is the Academy of Geriatric Emergency Medicine. It was formerly the SAEM interest group for geriatrics. And at AGEM, we celebrated our 10th anniversary at SAEM 20, but because it was virtual, we said we're going to pass off a celebration for another year or two. But the Academy of Geriatric Emergency Medicine has been around for 10 years. If you're not a member, now that Academy is free, I would say, think about it, please. Consider becoming a member. From our perspective, members include, of course, funded investigators conducting innovative, transformative geriatric emergency medicine research, and also thought leaders driving forward clinical and educational initiatives in their institutions, health systems, regionally, nationally, and internationally. What I think is most important about our community, and what I'm really proud of and really lucky, extraordinarily lucky to be a junior member of AGEM and of the geriatric emergency medicine community, is that it is an extraordinary mentorship network with more senior members advising, guiding, and supporting early career folks like us. In fact, when I was working on my GemStar application and my Beeson application, I had other Beeson and GemStar applications from colleagues who had applied for it previously. And I have also shared my applications with other colleagues, many of them. And I think that's a really important collegial way that we can help and support each other. And so from my perspective, the mentorship and us sharing is an important part of how we all work together. And I want to work with you guys. Let me know how I can help. In addition, if geriatric emergency medicine is what you're interested in, and I hope it is, think about becoming a member of the American College of Emergency Physicians Geriatric EM section, or GEMS. Think about the International Federation for Emergency Medicine. They have a Geriatric Emergency Medicine Special Interest Group that's led by a close friend of mine from Australia. And then the American Geriatric Society, many of us attend that annual meeting every year, and they have a medical and surgical subspecialty section that many of us have been a part of for many years. Also, NIAAA, or the National Institute on Aging, recognized that the GemStar program was one of their most successful programs, and that focusing on geriatricians and PhD scientists doing geriatrics research was simply not enough, and that focusing on other specialists that wanted to do geriatrics research or wanted to do research on aging was a critical way for them to improve understanding of care for older adults and to really optimize research into these areas. And so recently funded by both NIAAA and the American Federation for Aging Research is a program called LINSTAR. LINSTAR, it sounds similar to GemStar, and that's no accident. It's organizing, this group organizes activities and provides resources for the cultivation, connection, and synergy for early stage clinician scientists in aging research from disparate specialties. So starting to sound like us. It's a national platform to convey scientific and research knowledge, to foster networking and collaboration, to provide networking and career development support, and to advance disciplinary research. This is built out of the GemStar program and intended to make the program even stronger and more useful to folks like you and to folks that may not have a GemStar. And so here's the website, and you can see they list funding opportunities and pilot opportunities and career and research resources. There's a LINSTAR database that you can join. And here's the website. And I would strongly encourage you to peruse this website and to see if there are any opportunities that may make sense to you. Last, I want to congratulate, I don't know if he's on the call, but I imagine she'll watch this lecture if not, Dr. Ellen Sano, who is, I believe, or actually not I believe, I know is in this ARMED class. She won our ARMED scholarship. So AGEM sponsored an ARMED scholarship this year, and congratulations to Dr. Sano, who won. Her research focus on geriatric emergency medicine is on potential care disparities, mental health, and the impact of COVID-19, all critical issues. And Dr. Sano will present at the AGEM business meeting at virtual SAEM 21 as a result of having won this scholarship. And so congrats to Dr. Sano, and hopefully others of you will log into our virtual meeting and to hear Dr. Sano's talk for her. So that's what I have. These are my kids. They are at school today, thankfully, though we're hybrid, so they have not been at school for most of this week. But I'm happy to answer any questions. I hope this was helpful. And as I mentioned, or as Mr. Landry mentioned, and as I mentioned as well, this is the first time that we've given, or that I've given, or that I think that I've given, or that anyone's given this talk in the ARMED course. And so looking for feedback. If there are things that are helpful, great. But if there are things that are not helpful, or things that you'd want us to focus, or me or others to focus on more, please feel free to send Mr. Landry or Melissa McMillan at SAEM any feedback, and I'm sure they'll get it to us, or to me and to us. But I hope this is helpful. I really do strongly believe that this is an area of research which is an extraordinary opportunity for folks that are beginning their research career, and an extraordinary opportunity to build something that will really have an impact on patients. And if you think about it, in geriatric emergency medicine, you have an opportunity to do research. You have an opportunity to become the leader in your emergency department from the perspective of geriatric emergency department accreditation and clinical approaches and clinical protocols. And you have the opportunity to really have an impact beyond the specialty. However, as I also said, if geriatrics is not at all your focus, then I think that including older adults in your research and thinking about how your question might be different for older adults, I think is also a really important strategic approach for you, but also will be extraordinarily valuable for the patients that we all care for. And so with that, I'm going to start looking at the chat and take questions. And thanks again for inviting me. I hope this was helpful.
Well, thank you, Dr. Rosen, for this great presentation. I'd like to open it up now to Q&A. You can either unmute yourself, ask a question, or enter your question in the chat room. I see that there are already a couple of comments and questions in the chat. So, Tony, I'll let you go ahead and address those.
Sure. I'll start with medication safety and deprescribing in the elderly. I actually have a mentee who is a cardiologist who received a Beeson Award specifically for deprescribing among cardiology patients. And he's a mentee, colleague, and friend. And so the deprescribing is unequivocally a focus, as is medication safety. And so I believe that gemstars and Beesons have been awarded for medication safety and deprescribing. Both from the emergency department, I can't say for certain, but I think that both of those mechanisms that I have described, medication safety would absolutely be an appropriate topic for those. Ultrasound researchers. Again, I'm not the only expert on ultrasound research. I'm not an expert on ultrasound research at all. I would agree that nerve blocks that decrease opiate use in acute fractures is absolutely an opportunity but I might encourage you also to think about other opportunities as well. And again, I am not an ultrasound expert, but just in the spirit of brainstorming, you might think about if ultrasound is really the stethoscope of the 2020s, perhaps there might be an opportunity to do screening abdominal ultrasounds on a certain subset of older adults that present with a certain subset of complaints to find things. Again, older adults are more likely to have pathology, and so there might be ways to think about ultrasounds that can be done in a screening capacity to find things that might take longer. Or there might be opportunities to think about how ultrasound can improve the way we quickly care for older adults with high risk of pathology. Or there might be a battery of screens that might be possible for older adults that we certainly would not do for younger patients. So you can think about screening, I would guess. Again, you as an ultrasound researcher would know much more about this than I. But also I think there are opportunities to think about geriatric syndromes and whether ultrasound can find other things. Can ultrasound find acute hip fractures that might not be obvious on an X-ray? Can ultrasound, so that might be a geriatric example. Can ultrasound assess muscle mass to assess things that might be relevant in a more chronic way? Can ultrasound be something that's used differently in older adults because their muscle mass is different for procedures or for other things for which ultrasound is typically clinically used? Are there differences in the way that ultrasound should be interpreted in older adults in the emergency setting? Or are there differences in the way that ultrasound should determine next steps in older adults versus younger adults? So I would completely agree with you that nerve block is a very, very, very logical example and perhaps the most obvious, but I would encourage you to think, just as I have, again, just brainstorming about other possibilities, of which there are likely many, many, many more that I've just sort of off the cuff said here. And the ones that I've said here may not be great ideas, but I want you to think that lots and lots of things may be possible. Yes, excellent question. I see from Dr. Sano, does early career not mean early researcher? Absolutely yes. Again, unfortunately, there are two distinctions, and it depends on the grant mechanism and it depends on the specifics. However, I would encourage you, in answer to the question that Dr. Sano poses, to read the requirements closely, because different grant mechanisms are different, and to ask. Some grant mechanisms say very clearly you have to be between now, you have to be 10 years from having gotten your terminal degree. Others do not. They simply mean that you cannot have had independent or mentored research funding. And so it depends. Many are early researcher, some are early career, which is more narrowly defined. However, it absolutely cannot hurt to ask. And I would encourage you, particularly if you are someone that has been a clinician for several years, but is now thinking about a research career, that many of these are focused on transition to aging research. And so transitioning to research or transitioning to aging research, you may be able to apply for some of these, even if you are later in your clinical career. And so I would encourage you to read very closely, but also to ask. Yes, exactly. And I see Dr. Sano and others. So all of this stuff, again, some of these things are written clearly into the grant requirements, others are not. Even if they are, unless they are absolutely clear, I would make sure to ask and find out. Another piece of advice that I like to give, because I hear it a lot, is that NIH program officers are there for us. They're there to answer our questions. And so if you have a question, reach out to them. The other piece of advice that I've heard from Sue Zeman and other program officers that I think is also helpful, that and keep in mind, I'm simply passing this on. But from my perspective, another way that I might think about, the other thing is that you're wondering, gee, I wonder whether this research idea is good for NIAAA or a different institute, or how to position or frame the research that I'm doing for a specific grant award like the GemStar or like another K award or any award that you're thinking about, perhaps at NIDA or at a different institute. Here's the advice that I've gotten. NIH program officers are willing and enthusiastic about talking to you about your research. However, they get lots of inquiries. And so the specific aims page is exactly the unit that they are expecting, not more and not less. And so ultimately, one way to think about, when do I reach out to a program officer about my idea and what's going to come next and where to send it to and how to frame it, you want to have a strong specific aims page. If it's just a paragraph, I wouldn't say discourage you, but if you came to me and said, should I send it to an NIH program officer, I'd say, I think what I've been told is that you want to have a strong specific aims page. So for those of you, again, in this course, I suspect you have a strong mentor. I would encourage that it's a specific aims page that your mentor has already looked at and that you both agree is the direction that you want to go. But the point that I wanted to make is that you should not think you should not think of program officers as folks that aren't going to respond to email or that don't want to help you. If you have a specific question, reach out to them. If you want to ask about your research, again, I'm just sort of passing on advice that I've been given. but the advice that I've been given is that it really depends. That they really, really want to read nothing more and nothing less than the specific aims page. I think those are all the questions. I see, yes, that ultimately.
Hey, Tony, I just had a point to make about my question about the Beeson Award. It's not specific to geriatrics, actually. And it's an interesting, especially for emergency medicine, for people who have clinical experience, who say, you know, I would really like to do research. I think it is something that maybe the armed course could address, because there are some limitations, I think, in the funding. And maybe to get people to think, oh, it's too late for me, I can't get into it. But yeah.
I think that's I'm glad that you brought that up, Dr. Sano, and let me see if I can address it. NIH is built to try to support junior people, because they recognize that senior people, and by senior people I mean people that are already funded and so on and so forth, have a decided advantage. And so there are things like that you'll probably hear about in other lectures. That if you're a certain level of junior, then you get extra points on your application score. And if it is your first application for an R01, for example, then you get extra points. And I agree that all of that stuff, while designed with the best intentions, in some ways disadvantages folks who are truly new to clinical research, but aren't meeting that sort of junior, that junior just finished residency kind of junior category. And I think that my hope is that more and more programs are going to be removing those specific limitations and trying to cater those limitations towards junior, in the sense that you are turning to research for the first time. And as I said in my first answer, some do, some don't. Some may make exceptions that we're not aware of. Some may have ideas by reaching out to the program officer that a certain letter can be written by your chair that makes it clear. Others are requirements that are insurmountable. Does that make sense? So I don't have a great answer for that, other than people can and should continue to advocate. I would encourage people to ask, because you don't know if you don't ask, and to look for these opportunities specifically, because I think that Dr. Sano is absolutely right that this course is intended not only for people that are in a research fellowship, which they are starting right after residency, which may be some of you, but also folks that have said, gee, I've had 12 years of a clinical career and I'm really proud of what I've done, but I think that I can contribute differently, and I think I can contribute more. And then those people, in my opinion, should be looked at similarly, and not disadvantaged. And in some places they are, and in some grant mechanisms they are, and in some mechanisms they're not. But I would encourage you to ask, strategize, think about whether there are ways for folks to write letters. Think about whether there are things in the frequently asked questions, and so on and so forth. Think about whether people are going to be offering exceptions. The other thing to think about, and again, is that there are definitely exceptions around young, a year off for a young family and other things like that not a lot of us know about, that you should be focused on. And there already are, and there are going to be exceptions around COVID-19, some of which are already been released and some of which haven't. And a lot of these are around timetables, what makes you an early stage investigator, timetables around the research funding that you already have, how long you have to complete it, and so on and so forth. And so whoever you are, everyone's at different stages, but I would encourage you to become as aware as you can of those things and to ask as much as you can. And I think that that's another way for me to sort of emphatically plug, and I don't mean to emphatically plug AGEM specifically, but mentorship. Like, I got lots of advice. The bridge to a K, I don't mean to quote him because I don't think he made it up. But Jeff Caterino talked to me soon after residency and said, I'd think about the GEMSTAR, it's a bridge to a K. And that's where I came up with that terminology. And so I think that meeting with senior people is always going to be something that's valuable, whether it's in your area of specific academic interest, whether it's people that have had success in research at your institution, and whether it's people that have had success in research outside your institution. And I would say that it's very, very much harder and easier. I think that we all thought, gee, at SAEM, I can set up meetings and coffee with all these people, and it's going to be SAEM's virtual. But that may make it easier. You know, the people that might be hard to meet, you can set up a Zoom with them now. And so, you know, senior people, and I can speak primarily for geriatric emergency medicine, the senior people in that specialty are awesome. They are extraordinary. They are super supportive. But I'd like to think that senior researchers throughout our specialty, recognizing that there are few senior researchers in our specialty, are going to be generous with their time and going to be generous with their support and advice. I see Dr. Sharp has a question. Would fellowship 5 years from residency likely be considered the terminal degree? Tough to answer. The easier answer, unfortunately, is it depends. The answer, I believe, in some cases is yes, and in some cases is no, and you may need to get clarity. I believe in some cases the answer is yes, but unfortunately, I believe for some, the answer is no. So I see we're almost at the end of our time. I see some friends, so hi. And for other folks, again, I hope this is helpful. I know this is a small area of geriatric of emergency medicine, but I really do think that it's an area that that really has promise, and that, as I was saying earlier, and I saw someone pointed out in the chat, no matter what you're focused on, I think talking to your mentor and thinking yourself about the value of adding older adult patients to your question, both strategically and to improve the care that we provide.
All right, Dr. Rosen, I believe that was the last question and comment for today. Thank you, Dr. Rosen, for an excellent presentation. And thank you to everyone who was able to attend. Have a great day.
All right, thanks everybody. Stay safe out there. I know we're all in kind of an unusual situation, so I hope everyone stays safe. Thanks again. I'll put my email in the chat if anyone has any questions for me. Or maybe, John, can you just send my email out to the group? Is that okay?
Yeah, we can add it to the post to their community site.
Perfect. Thanks so much. Feel free to reach out to me with questions. Thanks, everybody.
Thank you.